You know that CDC has quarantined a Emirates airline at JFK Airport today. First time we've quarantined an airplane in a major airport in this country in probably 2 decades. We thought a lot about it in the late 90s and early 2000s, thinking pandemic, but this is one of the few events where that's really happened. It's going on as we speak. So our discussion now turns to, under the able leadership, ma sœur de Haiti, Nicolette Louissaint, to talk with her esteemed team here. We had a little team break huddle out here about the gaps and challenges that we've heard something about today. We've heard about definitions, we've heard about existing databases, we've heard about approaches that people are taking, but this group is going to sort of pick that apart a little bit and identify some gaps and challenges. It's all yours, Nicolette.
Thank you, Craig. Good afternoon, everyone. So I have the task of trying to facilitate a conversation about gaps and challenges without complaining for an hour. So we'll see how we do. Very excited to have this great set of panelists here to dive into the issues around gaps and challenges related to how we predict, prevent, and respond to shortages during events. And I'm actually going to ask for the speakers to introduce themselves when you give your first remarks. But because we really want to hone in on what happens during disasters, and I'm probably going to use disasters, events interchangeably, but thinking about public health emergencies, I'd really like for us to start by scoping a little bit and thinking about which types of events pose the largest challenges as it pertains to predicting, preventing, and responding to shortages. So maybe I'll start with Brad.
Okay, Lizette, thank you. I'm Brad Noe, and it's N-O-E, it's pronounced Noe. So can you imagine a guy in sales that started off with the last name of No? I mean, it's not a good way to go with your career. I'd like to thank the Admiral and others for inviting me here to represent Becton Dickinson. BD, for those of you who don't know us, we're the largest producer of needles and syringes in the world. On top of that, we're about an $18 billion publicly traded corporation. We are now the conglomeration of 3 companies, BD, CareFusion, and CR Bard. So it is a pleasure to be here today and have a discussion about this. My bio talks about my role as global technical manager, et cetera. I'm actually, primarily reason I'm here is because I manage our pandemic, flu, and national disaster planning for the injection systems business. So that is my responsibility. So let me give you a little bit of a history lesson that was kind of interesting. I was listening to the previous panels. In 1947, the War Department, I had actually looked that up, the War Department, which is the predecessor to the DOD today, actually approached BD and said, look, you know, you're a little too close to the ocean, so we want you to move from Rutherford, New Jersey, up to some other place so you can't be bombed by U-boats or bombers coming off of aircraft carriers. So in about 1960, we opened up a facility in Canaan, Connecticut, when we switched over from reusable syringes and glass disposable syringes to plastic. But they actually approached us. The government was actually thinking about that well in advance in anticipation of things that could happen and go wrong. So let me kind of move us forward. Just one interesting statistic. In 1964, when we opened our Canaan, Connecticut facility, in the first year we produced approximately 10 million syringes. That same Canaan, Connecticut plant today this year will produce 1.4 billion syringes. Okay, and that's only 1 ml through 10 ml. All right, so just to give you an order of magnitude of some of the types of technologies and changes that have occurred in the demand in the US market and in the Canadian market. So let's talk a little bit about disasters and what happens for us from a BD perspective. You know, we've heard a lot about IV bags, but at the same time, as you've also heard from Carla and from Scott previously, when pharmacies run out of IV bags, what do? They switch to the next best alternative. And Scott had that great diagram about the triage of which different reservoirs to use. Okay, syringes happen to fall at the bottom. Okay, well, not by design, but because it's, okay, let me go through these first, and then I'm gonna get the syringes. So we watch where the drug shortages take place. But as people get creative about what they're going to do and how they're going to use them, they start using syringes for all kinds of different things. And for those of you who have any clinical background, you know how ubiquitous syringes are used for anyway. So when you add all this up and then you add this added change in this demand, it gets rather interesting. At the same time, in the US market, we've had kind of the perfect storm. We've had a consolidation in the marketplace of manufacturers. We're down to basically 2 majors. Okay, there were at one time 4 or 5, now they're down basically to 2. One has exited the market, another one is no longer able to produce into the US market. So it gets kind of interesting. So let's talk about how we're impacted as a manufacturer by disaster. I'm not talking about demand. I'm just going to talk about natural disasters that occur that impact our ability to supply. So right now, it was mentioned previously that there is a hurricane coming up through the Gulf, okay, and they're watching it carefully. I'm going to take you back to 2005 when we had Wilma and Katrina, and where did they go? They went right into, well, Katrina basically followed what's going on right now right into New Orleans, okay? However, Wilma hit the Gulf and Galveston. For those of you who don't know it, 45% of all the petroleum refinery in the United States takes place right in the area of Galveston. What are needles and syringes made of besides steel cannula? They're made of polypropylene. Where is that refined? Galveston. So BD, luckily the good news is most hurricanes have a tendency to move slowly. We were able to actually put something in the order of about 30 rail cars of petroleum polypropylene pellets in Kansas City on our side rail, basically waiting for the fact for this to blow through because our supplier had already told us we're going to shut down the refinery. We're shutting down these things. Take what you can get. We moved those rail cars up to Kansas City, and by the time we were able to move them across the country and get them to both our Columbus, Nebraska facility and Canaan, Connecticut, we were within literally a day of shutting down both plants. Okay, so when we think about disaster, we think about demand. When I think about disaster, I think about it from 2 ends. I think about it also from the supply factor of raw materials, and I also think about it from the standpoint of the incremental demand that we're going to have to either meet the needs of the clinicians, backfill the pipeline, et cetera, and a whole host of other things that are going to go on. At the same time, also we had back in, I think, 2006, 2007, we had our stopper manufacturer's plant in Kinston, North Carolina, blew up. Literally. You know, somebody made the comment about their supplier blew up, no plant can blow up, stopper plant blew up. Okay, we were literally taking 747s, bringing them in from Spain with literally huge containers of rubber stoppers and being able to supply them to put them into our syringes to continue producing it. There was not a hiccup in the US market. Why? Because we had a huge team that went to work on it, but those are the types of things we have to worry about. So how do you figure for contingencies? That gets to be a real interesting challenge. So we look at alternative suppliers. We look at a whole host of different things. We're also looking at where do we put our plants to make sure that they're out of harm's way to the best that we can go. I'm not going to get our refinery supplier to be able to move their facility. That's not going to happen. So we have to figure out contingencies. There's a lot of things that go on with that. So when you think about it as far as disasters, we think about it a little bit differently. So it's not just, it's also, you've heard a lot from the manufacturers, from the drug wholesalers and drug suppliers about API and a number of other things. And then you look at the pipeline that goes with that. A lot of that's offshore today. So in the event if we had a pandemic, you'd have border shutdowns, right? Borders are probably going to get closed. So how are you going to get your stuff in? That's not going to happen, all right? There's any number of things. So what do we do in lieu of that? Okay, and I hate to sound like the harbinger of doom, but those are the types of discussions. But I'll give you some uplifting information or share with you some good things. Pat Byrne did a great job of providing you with some background about private-public partnership. We've been engaged with BARDA and with Pat and his team for a while now, but even more so, we've been involved through HIDA, through Linda Rouse O'Neill, her group, and also with the Strategic National Stockpile, and actually doing tabletop discussions about solutions and data. Okay, the big conversation we've been having, not a big conversation, but a discussion we've been having about data today, about availability of data. We made a conscious decision as a corporation to be transparent about our data. We pay huge sums of money to obtain market usage data, and we found that the SNS didn't have it. Now, that's silly, okay? So we said, we'll share it, because you're trying to develop, like Pat said, they wanted to create a situation where you could have access to 600 million syringes, okay, of a certain size and a certain design and everything else. Well, the market's 4.1 billion units, okay? But of those, that represents considerably much smaller. What they really wanted is only about 18% of that 4.2 billion units. So you do the math, okay? It basically would wipe out the entire US healthcare demand for about 15 months. That's not gonna happen, okay? So when you start backing into these things, you realize maybe we ought to share the data and come up with a little bit different way of looking at things. So we've been doing that. So for the last 18 months, we have been actively engaged with the SNS in sharing that kind of information. We're getting to the point now where we're helping them to develop and working with them to develop playbooks so that they would share it with industry, so that when they say, oh, we've got this kind of an outbreak, we know what they want, how much they want, where is it, what's the population, what's the treatment plan look like, what sizes do they want, et cetera. So we can start to muster the appropriate resources around it, sequester items, do a number of different things to be able to try and put that in the right place at the right time. But 18 months ago, somebody stuck their hand up in a meeting and said, well, we need 600 million 3 ml syringes. And I said, well, the problem with that is we only produce 400 million a year, and you want them in 6 months. So I think we need to go back to zero and start working our way through it. So I think we've actually progressed rather substantially in a short period of time. It started off with C-Spot Run. Now we're at a point now where I think we've moved much further, and we're moving further along all the time. You know, and on top of that, we're working with BARDA and others to try and get us to the point where it really is a conversation. It's not a he said, she said. It's not them versus, us versus them. It's really trying to come together to try and make sure that the clinicians can continue doing their work with minimal disruption and transparency, and then we can share. And then I think the other key thing came to mind was also making absolutely sure that we're all saying the same thing. So if you go to one source, it's not like today in some cases you go to one source, you get one source. We hope to get to a point where you go to one source and you see the same thing ad nauseum. So you go on a BD website, you go on this website, you go on that GPO website, you go on the FDA website, it all says the same thing. So as providers, you can look to one place and say, oh, I feel good with this. Oh, okay, I'm cool with that, So in general, we've made a huge amount of progress. What we don't want to do is revisit what happened I know we beat up 2009, the pandemic. I actually had dark hair when I started in 2009. Yeah, I know. Look down. Grecian formula was not working. But basically in 2009, it took BD 18 months to recover, because of all the seesaw of different products, demand, all this other stuff that went on. 18 months to recover to steady state. That's unconscionable. And the amount of disruption that happened along the way, and our ability and the beatings that everybody took along the way, it's the wrong way to approach it. So that's why we decided, let's take a new approach to this. And we've luckily had the opportunity to work and have voices that are willing to listen back and have good dialogue. So.
Thanks. So Eric, from the perspective of Brigham Health, what types of events pose the greatest gaps or challenges from your view?
So I'm Eric Relnick. I represent Brigham Health and the emergency preparedness community and our team. Essentially, Brigham Health is comprised of an 800-bed academic hospital in Boston, Brigham Women's Hospital, Brigham Women's Faulkner Hospital, which is a 150-bed community hospital, about 200 ambulatory clinics, and that's part of Partners Healthcare, which is about 10 acute care hospitals, extended care facilities, rehab facilities, clinics throughout Massachusetts. It's one of the larger providers in Massachusetts. So the question around what hazards am I concerned about, we're trained with the mantra of an all hazards approach, and we do our annual hazard vulnerability assessment. But the truth is, right now, I think someone had said there's 5,400 hospitals in this country. And in many of those hospitals, we're at or over capacity. Right now, there are patients in hallways getting suboptimal care. So regardless of the hazard or the event, whether it's a natural disaster like a Hurricane Sandy, and we were just in this building, when was that, Dan, 2 or 3 years ago on a workshop, a day-long workshop on Sandy, whether it's a natural hazard like that or whether it's a cyber attack or the Boston Marathon bombing, if we're always functioning over capacity, any one of these challenges can impact any one of our supply chains. And in addition, not only our supply chains, but most importantly, the care of those patients in the hallways, the care of those patients throughout our hospitals and our clinics.
Thank you. James, from your perspective, what are the hazards, the events that you are most concerned about and would pose the greatest challenge from your view?
It's a really good question. So my name is Jim Grant. I'm currently the president of the 52,000-member American Society of Anesthesiologists, and I chair the Department of Anesthesiology at Beaumont Hospital in Royal Oak, Michigan, which is a 1,100-bed acute care level 1 trauma center facility. So what events affect our world? You know, I've got to say everything that Eric gets, I get next. Mm-hmm. Usually they come to Eric first, then they end up in operating rooms, and then into intensive care units. So it's sort of a tandem approach here. It's interesting because we actually, when you go to work every day, it used to be I'd go to work and I'd say to myself, how am I going to take care of this patient, that patient, and that patient? I don't say that anymore. I say, will I have the drug to do this? Will I have the drug to do that? And which pharmacist is maybe stashing away an emergency supply of something that they got last week that they knew that there were 3 ampules left of? So our world has changed, and it's changed really quickly. We used to get drugs. You know, we all had drug shortages. I can remember we had a propofol shortage, and someone mentioned propofol before. It lasted a couple weeks, and then we got it back. This is like an everyday occurrence now. I'm telling you, we're not going to get it back for a couple months. Or actually, you know, possibly into mid-2019. How do we deal with disasters? We ration. We ration every drug that we possibly could think of. We're not talking about anymore, we're not talking about the drugs that we can have a substitute for. I mean, one of the calls I tell you about a call I got just last week. And as the chairman, they call me about these things really quickly. So a recovery room nurse calls me and she says, Dr. Grant, we're out of labetalol. This is a drug that can treat acute postoperative hypertension. It's like, okay, let's move to hydralazine, which is a vasodilator, which can also acute postoperative hypertension. Now we're out of hydralazine. So I thought we got that back, and we got very little, now we're out of that again. Okay, and then she gives me, I said, well, what do we have left that's in the Pyxis machine? And she says, well, we've got an ACE inhibitor. And as Michael will tell you, sometimes postoperative hypertension isn't really that great with IV ACE inhibitors. So I finally, because you know, if someone's going to complain, they have to complain to the chief. So I finally said, you know, are we just going to move to yoga as the next therapy? And that's our lives every day now. So if we have something come in, if we have, you know, in our world, we used to always talk about if a busload of hemophiliacs shows up, we don't even need a busload of hemophiliacs. We just need 3 or 4 sometimes patients who need acute care. If I would have told you 3 or 4 years ago, if we had a crisis and we had a trauma come in and we had no epinephrine, we ration epinephrine now. We ration it. We have X number we need for intensive care units. We have X number we need for open hearts. I mean, our world has changed on a dime. We're trying to figure out every day how to do the best we can. Part of it is we're finding a lot of substitutes. As far as I know, we're not really canceling a lot of surgeries. We can't cancel. You can't cancel. We have a problem with local anesthetics. So if we all of a sudden had 5 or 6 women that needed emergency C-sections, that again is a disaster. What are we going to do? The local anesthetics give them spinal. We're using other drugs, and we tell them, you know, you may feel your block a little high for a few minutes, but we'll work your way through it. It's not great care, but we're getting through it. So these are like I said, the challenges that we're figuring out every single day. And what drugs do we have? Most people, you know, if you're a journalist or if you're in industry, you're not saying to yourself, well, I hope I have a computer when I get to work that day. In our world now, we're just hoping we have the drugs we need to take care of people. And it's like I said, it's an everyday occurrence, and you hope the busload of hemophiliacs doesn't come in, because we're going to do everything we can and scrounge around and go to other units and see who has a stash somewhere just to get the drugs we need. We've got pharmacists that are constantly just on the phone, cutting deals with other places. You know, if I'll trade you four cases of bicarb if you give me two fentanyl. So we got a deal. So it's like our world has changed upside down in a short period of time. Michael. No.
Don't tell the DEA about the bicarb for fentanyl trade, please.
Mike, please, from a SHP's perspective.
Sure. My name is Michael Gagno. I'm Director of Pharmacy Practice and Quality at the American Society of Health System Pharmacists. We are a professional membership association that represents pharmacists who are healthcare providers in hospitals and ambulatory settings. Our 45,000 members are mostly comprised of pharmacists, pharmacy technicians, and student pharmacists. And we provide leadership on pharmacy practice-related issues, policy advocacy, continuing education. We have a peer-reviewed journal. And our vision is that medication use will be optimal, safe, and effective for all people all the time. And the unfortunate fact is that in the current landscape of drug shortages, it's just not possible. So as you've heard, we're constantly looking for what is our second-line alternative, or how can we compromise, how can we conserve, and so patients aren't necessarily getting their first-line treatment. So one of the other major resources that we provide is information about drug shortages. And you've heard earlier today about the difference between how the FDA defines a drug shortage and how ASHP defines a drug shortage. Our database for drug shortages is managed and maintained by the University of Utah Drug Information Service. And the way we look at drug shortages, if there's any instance of a patient or a provider who can't give that agent to a patient, that's a shortage as far as we're concerned. Because if globally there is enough product to meet demand, that doesn't mean that every single institution, that every provider actually has it in hand to give to a patient. It could be that the shortage hasn't reached a scale yet for the FDA to call it out on their website. It could be that one particular manufacturer is making enough, but if an institution doesn't have a pre-existing relationship with that particular manufacturer, they cannot get product from them. They don't have that pre-existing buying pattern with them. So we try to provide resources for all the shortages that affect patient care. We also have guidelines on how to manage drug shortages. We put out FAQ documents for specific shortages, the saline shortage, for example, or the injectable opioid shortage. And one of the frustrating things, we're very pleased to be invited and to participate today, and seeing all these different specialties calling out drug shortages, but we've been doing this for decades. And so my colleagues in anesthesia and in emergency medicine and probably in parenteral nutrition have been hit the hardest. But unless something affects your specialty, like clinical oncology or cardiology, you may just see a warning come across your electronic medical record, or you may see something come through your email that says, hey, we're out of this drug. You read the email, you move on because it doesn't really apply to you. Well, every time you see that, it's affecting pharmacy. The good news is we're getting good at managing these. The bad news is that it's taking a toll from resources and from personnel and time, very time-intensive processes to manage these. Last November, ASHP, along with ASA, Aspen, AHA, several other professional medical organizations convened a roundtable. And the purpose of the roundtable was to look at shortages and to find out how we can to start to address these. And basically the exact same themes you're hearing today. It's transparency, it's information. How long is this shortage going to be? What is the cause of the shortage? If it's a problem with raw materials, I have to start looking at all the other products that are made from that raw material and to say, is that going to be next? Is it all the generic suppliers of that medication, or is it just one supplier? If it's a quality issue, it's likely one supplier. I can try to move on to another. How much do I have on hand? How long is that going to last me? What are my alternatives? And so ASHP tries to step in and offer some resources there, and of course the advocacy and participating in events like today. But I would echo what my colleague, Dr. Knorr, said earlier. All shortages are essentially a disaster from our perspective. They all require some sort of action that we have to take.
Thank you. Elizabeth, 2 years ago, Pew did a report on this very issue, and I'd be interested to get your perspective based on the report about the hazards of greatest concern.
Sure. So I'm Elizabeth Youngman. I direct public health programs at the Pew Charitable Trust. For those of you who don't know us, Pew is an independent, nonpartisan research and policy advocacy organization. We work in a wide variety of areas, including a longstanding line of work trying to ensure this quality and safety of pharmaceutical products, and we look at that from a number of angles, including drug shortages. We were engaged back in 2012 in the negotiation of the legislation, the FDA legislation that was about drug shortages. At that time, I was Health Committee staff, so I have that perspective as well. And since then we've participated in a number of these conversations, including ASHP's roundtable. And then, as you mentioned, in last year, we partnered with the International Society for Pharmaceutical Engineers, who are represented in this room too. So y'all speak up if I'm getting any of this wrong. To publish research that really examined how companies make decisions about factors that affect drug shortages. So these are, manufacturing, maintenance, facility upgrade decisions. We did that by interviewing more than 50 executives from 10 pharmaceutical companies of varying sizes that covered products, branded generics, and generic products. We also took a close look at case studies of sort of 29 case studies of shortages to try to really kind of check ourselves to make sure that what we were hearing anecdotally from pharmaceutical companies was really what was tracking the actual sort of lived experience in those companies. Understanding that quality issues continue to be the driving factor behind most drug shortages, the focus of this report was really about what are the factors other than quality that contribute to shortages. And some of those factors, including how manufacturers make decisions about business continuity planning issues. So how do they respond to market withdrawals? How do they make decisions about things like dual sourcing? May be relevant to this discussion. So I suspect that that's how I snagged my invitation to this party. I will get to your question. I just want to, because this may be relevant to the discussion, and by way of introduction, also mention that another issue area that Pew is very involved in is that of drug compounding policy, and that's also something I was engaged on when I was on the Hill. And so, recognizing that there are risks to compounded products as a substitute for approved products, that they can be a helpful, source of product in circumstances of drug shortages. And so happy to really kind of talk about how compounding policy intersects with drug shortages policy as well. But, looking through the lens, you asked the question in the context of this report, and so looking through the lens of that report, you can't plan for what you can't predict, right? And so, I think we have seen in our research that companies can and do take steps to plan for shortages. I think there's lots of questions that we can get into about what are their incentives to do that and how does that vary by product category. So there are reasons that they don't. But even if you get the incentives right, you can only really plan for what you can predict. And so, your question was, what are the big challenges? What are the things that scare you? It's the things that even if you get all the incentives right, if they're not the types of questions that you can build into business continuity planning, then the sort of the lessons that we learned in our research aren't going to really help you out.
Absolutely, thank you. So two of you have already touched on the question of current initiatives, but we, I think, have heard throughout the day a desire to know more about what kind of partnerships exist or should exist. So thinking about current initiatives that you are a part of, do the rest of you have any initiatives that you'd like to highlight as examples of work that might be going on to address these gaps and challenges?
So, is my microphone on? Yeah. So one of the things, and this actually came, it's amazing the things that can come up from the grassroots. So we had an anesthesiologist in this past August who said, came up to me at a meeting and said, Jim, can we find out who's having what kind of problems in the country? So Ashley Walton, who's out in the audience in here, and I worked on a project together where we said, you know what, let's see if we can send an e-blast out to all of our members. Now, we don't really respond to email blasts and surveys that well, but we sent it out at 5 a.m. on a Monday morning. We had, in a 1-hour period, 2,500 anesthesiologists that responded. I don't have labetalol, we don't have nitroglycerin, we don't have epinephrine. 2,500 in an hour. And they were just giving a story after story after story. And these stories, we took these stories up to the Hill, and we were able to get some action. One of the stories were probably had a powerful impact to create the task force that we need so badly. So this is grassroots coming up, telling everyday stories, what's going on in operating rooms, emergency centers, intensive care units. We don't have the drugs we need. So we took that success and we took it to the next level. So we worked for many months to create a national drug shortage registry so that anyone, not just anesthesiologists, not just ASA members, can actually go to our homepage of our website, hit drug shortage, and report the specific drug shortage that you're having at that specific moment. Because you may have drug A on Monday and plenty of drug B. Tuesday, you may not have anything. Thursday, you may have everything you need, and it's inconsistent. There's no consistency to it. So this is one of the things that we're working with, I think it's September 20th, which is 3 weeks from today, Michael? So the ASA and the ASHP are actually hosting a roundtable again, where we're bringing all the stakeholders together to discuss what are the issues and how can we move together and how can we work with the FDA and how can we work with the DEA and how can we work with Congress so that we can be proactive and not react to these situations. I like to tell a story when I'm talking to physicians. So I'll go to a group, 100, 200, 300 anesthesiologists, and I'll say, who hasn't experienced a drug shortage in the past 6 months? I haven't had one person raise their hand. Everybody has had an issue. So I say to you, who in a million years would have ever thought that 80% of our hyperbaric bupivacaine, is what we give local anesthetic to pregnant mothers, was all made in the same factory in McKesson, Kansas? You never would have thought a country of our size that would happen. Or our 50 cc bags of normal saline, like someone just said, it's just salt water. 50 cc bags of normal saline were all made in a hurricane vulnerable area, shut down. Now we had a shortage of that to begin with. The hurricane was just the final blow. So these are things, we can't react to them anymore. We've got to be proactive. We've got to constantly be ahead of the game now. And pharmacists, got to give them credit. They're working with us hand in hand, and they're just trying to stay 2 and 3 steps ahead. So that's...
Yes.
Completely agree. And the meeting that's being hosted on the 20th is similar. What we're actually focusing on is a national security issue. The concept of drug shortages during, or any medical product shortage during a disaster is important, but we're exactly trying to be proactive and look at what are our vulnerabilities. Our products are sourced overseas. What happens in a trade war? It was brought up earlier today. Or what happens if someone has even more nefarious intent and knows how to get something into our drug supply that goes in? You look at the valsartan recall that was discussed earlier today, and unfortunately with the impurity of NDMA, what if something like that were to happen and be intentional? So we're trying to be proactive and look at it from all angles to see what are the vulnerabilities of our drug supply chain from start to finish.
So, the conversation today is really inspiring, and people are leaning forward as opposed to leaning on their back foot and thinking about how to navigate this. But one of the voices just listening to today that we're missing is patients, right? We're thinking about patient advocacy groups in the conversation, and when we thought through some of these solutions, that James, like you're talking about, and we'll list out those solutions, but we had our anesthesiologists, our pain management specialists, look at our current inventory, look at our predicted shortages, come up with some alternative solutions, push that information across not only our system, but across partners and share it with other systems. But the challenge is we're working on our perception of changing some of those pain medications, and we don't really understand the impacts on patients. We're using pain scales that are very subjective and are very archaic, quite frankly. So thinking about what are the true impacts, and when we talk about, one of the questions earlier was around measurement, we've talked about a lot about the supply chain. What's the measurement on patient-related outcomes, frailty scores, and all the various patient measurements that we could think of? And we've got to maybe create some new measurements. So what are the innovations that we did at Brigham and through partners are a couple. First, which has already been talked about at one of the earlier panels, was leveraging our electronic healthcare record system, which again is a vulnerability, which I'll get to in a second. We use best practice advisories, so we're all used to that. When you order a medication and something pops up that there could be a contraindication to this medication because they're already on X medication. The challenge with that now is that our clinicians are getting these best practice advisories on a ton of different types of medications and fluids, and they have alarm fatigue, along with the emails that go out on a regular basis. And our pharmacists have been leading the way. They've been troubleshooting this for a long time. We implemented our incident management team several months ago, which is various disciplines from all the various clinical departments, nursing, physicians, administrators, and again, pharmacy leading the way in really coaching us through each of these challenges and how we can navigate that. But despite that incident management effort of getting that information out, it's challenging when the end user, the clinician that's touching the patient, is getting all of these different modes of communication along with all of the other responsibilities that they've got to perform, which all contribute to this issue of burnout across clinicians that we're experiencing today. The other piece that we did is we implemented a call list, essentially. On a daily basis, our pharmacy team would lead an analysis with our information systems team, and they would look at every patient that was mismatched around those that were receiving a PO diet and were receiving IV fluids or IV medications. That clinician, the ordering provider, would get a call from the pharmacist, from one of the pharmacists on the team, to ask about that order and see if they can convert those IV medications or fluids to anything PO. And we found that that was very productive, and we measured that, and over time we have the data from that effort. But again, it speaks to the effort of those pharmacists, of those clinicians. It also degrades some of the relationships. If you're getting a call every time you order a medication, it's challenging. And people were very good. They acknowledged that this was an issue. But again, they are inundated with all of these different interventions and programs and issues, and drug shortages are just one element. Around public and messaging, not only publicly but internally, we set up an intranet page. We had FAQs that could be handed out to patients, frequently asked questions. We're in a national drug shortage. These are the reasons we know of why. Here's the information we know. Here's what we don't know. Here's how we're filling the gaps. And really employed our public information specialists to help us communicate with patients and communicate with our staffs. So those were some of the interventions that we did over the last few months.
Great, thank you. So one last question before I turn it over to the audience. What are some of the gaps that you observe in responding to shortages, especially during disasters? There's been a lot of conversation about some of the gaps in preventing and predicting, but really interested in getting your perspective on the gaps as it pertains to responding to shortages, and if you could offer some root causes as well in your response.
Happy to jump in. Sure. So, well, I can kick that one off. I think if we want manufacturers or outsourcing facilities, for that matter, to step in to mitigate shortage, to be helpful in that circumstance, there are steps that would have to be taken to make that make financial sense for companies. And so, at least what we heard in our research was that some of the challenges to manufacturers stepping in those circumstances where they're being called on to mitigate are either that it's hard to predict the sales volume, so you don't know exactly what you're going to be called on to do. And that you're going to, you worry about getting stuck with inventory once the original manufacturer comes back online. And so, 4 out of the 10 companies in our research identified circumstances where they had taken over a contract to address a drug shortage situation. The original competitor came back online, and they got stuck with a whole bunch of unused inventory. And so, you can sort of see why people, they don't make the decision to step in when they could. And so, there are a variety of potential solutions there. One of the ones we talked about in the research was, using contracting mechanisms to permit those who sort of step in to retain contracts for a certain period of time that could be pre-negotiated. That's the kind of solution that, either the purchaser, the GPO, or, government purchasers could employ to really try to make it make a little bit more sense for folks to step in and help out when they have the ability to do it, but then, it may not make financial sense for them to do so.
I can answer as well, and I will come back to information again, and timely information. In the event of a disaster that we can somewhat predict, like a hurricane that is targeting Puerto Rico, for example, clearly there's information out there. Someone has the information, the FDA or the manufacturers, of what's made on that island, what's at risk, to allow, you've heard of the fatigue and all the preparedness that goes in on the front lines to get the EMR updated, to start putting contingency plans into place. If I know 2 weeks in advance that the shortage may hit, I can do all that more efficiently and more safely than if I have to find out when I order from a wholesaler that I'm not going to get that drug this week. So that timely information is critical, and I think it's one of the biggest gaps. In the event of a disaster that you can't plan, the same thing is true. First and foremost, the lives and health and well-being of those in the area of the disaster are important, but then stepping back, analyzing the infrastructure impact, analyzing the manufacturing capabilities and what reduction in the capacity might result from the disaster, and then making sure that information is available, and pulling wholesalers in. I know we heard from a wholesaler earlier today, but they will often put institutions on allocation as soon as they know there's a shortage. Well, if they don't know that most of our small volume saline bags are made in Puerto Rico when that hurricane hit, they don't know when to start allocating until they don't get supply either. So I think that timely exchange of information is a huge gap in being able to respond to shortages.
Well, I got to sort of dovetail on what Elizabeth said, because when we go around, when you talk to our members, the first thing they say is, well, why don't you just import it from Canada, import it from Europe, import it from Japan? And you explain, listen, there's a lot of infrastructure that's involved, and they're all saying to themselves, we can bring it into the U.S., but when your production's ramped up again, where are we going to be? And they've got a point. So we've got to make it more user-friendly to use other countries as a backup for us. We've got to figure out a way that we don't have sole sourcing. And like what Michael said, drug shortages, they may be part of our new fabric, that we're constantly going to have to be able to be projecting what are we going to have, and what's our supply chain, what are we going to have 3 weeks from now, 4 weeks from now, 5 weeks from now, and we have got to make sure that we don't have any 1 or 2 factories in the country that can shut down a whole country like ours.
Yeah, the other piece is changing the demand curve, right? And we practice in a certain way, right? A lot of patients get IV fluids, right? We trialed a program where we actually, our global health section said, let's try PO hydration formulas and let's reduce some of the IV fluids. And the challenge, and they did a great job, but guess what? We don't actually know the impact of that because we don't have great real-time data collection and we don't have good predictive analytics. So we've invested heavily in Epic, for example, electronic healthcare records. And so we've got to think about ways to leverage that to get real-time data and predictive analytics to move innovations forward and focus not only supply, but the demand curve.
It's interesting listening, to the comment by Jim and both by Eric. We have multiple facilities around the world. The unfortunate, it's kind of a shame on us, is that not all our syringes are made to the exact same dimensions and expectations of performance. So, especially for an anesthesiologist, you get a 60 ml syringe in from Europe, it says BD on the outside. You go to put it in your pump, you're going to get an error alarm because it may not have the same dimensions, may not have the same breakout forces. You do it for pediatric cases, ER, you're pushing something that doesn't work the same way, creates more hassles than it's worth. So we're spending a lot of time and effort trying to standardize that in lieu of a lot of the situations that we have. The other thing that occurs here is, from a manufacturer's perspective, is it's a low growth. Syringe and needle business is less than 1% growth on an annual basis. So from an economic standpoint, investing in excess capacity isn't really high on someone's list. You try and get capital They want to go for the higher margin, higher value, which is why you're seeing contraction in the market. Very similar in nature to the generic market. But at the same time, what you're also looking at is trying to, when you have situations like this, you have shortages, we end up making decisions that we end up having to communicate to our customers. Not always the most popular. So we make, right now, about, for the US market, we make somewhere in the neighborhood of over 235 different needles and syringe combinations. Syringe only, syringe and needle combinations. So what we end up doing is we say, look, folks, 85% of your market's Luer lock syringes. All we're going to do is make Luer lock syringes. We're not going to run syringe and needle combinations. We'll run the needles separately. You guys can put them together. Oh, no, you can't do that. Well, why not? Well, because it's inconvenient. Look, folks, it's real simple. You either get them or you don't get them. It's one option or the other. And that's basically where we come down. It's a harsh message, so we try to temper it down a little bit. But sometimes you got hospitals that look at you like you're crazy. You got to keep producing. We're saying, so Eric, in all fairness, Tetamel Luer lock, that's what you're going to get for the time being. Can you operate with that? You probably say, yep, as long as I have syringes, I'm fine with that. I'll make do with it. But we have facilities that, oh, I want it this way, I won't accept it that way. It gets to be a challenge. But those are the types of decisions we make because we know also that if we break into the line, we take that 6 to 8 hours down out of a piece of equipment that makes 100 million syringes a year. That's a lot of syringes. So when you start making decisions like that, you're trying to look for efficiencies to try and get back up to speed to be able to produce it so you guys don't have to worry about it. Those are the things that go on. But we try and do communicate those things. But again, it's not simple, and you just don't go to Home Depot to buy this equipment either. So it's a rather complicated set of circumstances. And again, we can't switch manufacturers or suppliers relatively quickly, because that is typically a 12 to 18-month validation process. So if we go to switch resin suppliers, it's 12 to 15 minutes. 12 to 15, I'm reading something from the back, my apology. 12 to 18 months. So.
With that, we will turn to the audience for questions. Please use the microphones in the aisle and remember to state your name and affiliation.
My name is Sheldon Jacobsen from the University of Illinois. Fascinating discussion. We often think of the extreme cases of a major disaster, but you're talking about routine shortages that are threatening people's lives. It's absolutely fascinating. I like to think of exercises, and one of the things is, suppose we viewed the supply chain as a human being who is sick. Would the problems be chronic, or would the problems be acute? From what you've said, it sounds like they'd be more chronic than acute, although there are acute issues that come up, and you can comment on that. But one of the maxims that I live by is that you can't solve a global problem with a local solution. And I apply that principle in many areas of my life, that so often we focus far too myopically, yet the problem is more systemic. And I welcome your comments on how this all fits together based on those perspectives.
Sure, welcome one person to respond.
Yes, sir. Acute and chronic. Well, like all diseases, sometimes they start acute and then they become chronic. Our goal is that it doesn't, still chronic diseases are cured. That's our goal right now, is to cure the chronic disease. I mean, 2 years ago, we didn't have these issues. So yeah, 18 months ago, they were acute. Now they've become chronic, part of our everyday landscape. But we're working towards fixing it so that, there is a cure at the end of the day. So that's sort of my answer to the acute and chronic. And global problems that can't be, you're right, global problems don't have a local solution. And I think everything we've been talking about here, I know everything we talk about ASA, ASHP, ASAP, we're just sitting there and talking about global solutions. We're not talking about a lot of local, we're talking global, because we know global is where the problem is. It's not local. Global is where the problem is, and that's where we're focusing it on.
I might just add to that it's not just one problem, and that's it's part of what your acute chronic question brings that up. That if there were a cause, it would be a lot easier to tackle this mess.
Next question.
Hi, I'm Matt Winnie. I'm from Colorado. I wonder if we could return to a question that was asked earlier around engaging patients and the public in these conversations. I was thinking of that as I was listening to you talk about as clinicians, what I was hearing is what I would call moral distress, right? Moral distress being the circumstance where you know the right thing to do, and there's a systemic or organizational barrier that prevents you from doing what you know to be right. And people who experience moral distress burn out. And this has been a big chunk of the burnout conversation in healthcare, is putting health professionals in circumstances where they know what they need to do and they can't do it. And one of the ways that we try and address that is by sitting and talking with all of the stakeholders who are affected in those circumstances, whether it's in an ICU or whether it's in a C-suite. And it just is striking to me that patients are receiving care that we know to be inferior to our normal standard, and they don't know it. And that has to, I'm an infectious diseases, so I can tell you, as I've been sitting through the day thinking about this and realizing I have made decisions to give someone a second-line antibiotic because we didn't have access to the first line, and I didn't tell them that. And I'm not sure how to get to the place where I could tell them that, because honestly, that would open a whole rationing can of worms, which we know from research patients don't actually love talking about, and they certainly don't like the idea of rationing being applied to them individually. But I am wondering how you are dealing, or if you're dealing, any of you, with the inherent moral distress of being a clinician in an environment in which necessary medical supplies are not available.
Why don't you tell them? Why don't you?
Why don't I tell patients, well, there's a good drug for you, that one's not really available, so I'm going to use the second line?
I think that's a conversation that, I certainly feel empowered, and I would encourage people to be transparent.
Have you had that conversation with a patient?
So I've had conversations with patients. So I'll give you an example about IV fluids. So we give them an FAQs, which has information about our IV fluid shortage, and have a conversation with them to say, listen, I think you've got a viral syndrome, your heart rate's a little bit fast. We could normally give you IV fluids, but we're reserving those for sicker patients in the hospital right now. I'd like to try you on this oral solution. It works very well, and our team of our global health experts have worked on developing a protocol for us, and here's some information about it, and the nurse is going to come talk to you about it, and then I'm going to come check on you in a few minutes, and here's this information sheet on that care. I don't have a sheet on antibiotics, but the point is I think we owe it to our patients to be transparent, and we've got to work through these challenges. And I agree, this all contributes to the burnout conversation. So for us as clinicians to navigate this moral hazard, I think part of it is to be as transparent as possible.
Our time is up,
Okay.
unfortunately. I think this is a great conversation for the reception this evening. Please join me in thanking the panel for their contribution. Turning it back over to the chair.
Pre-op when we say, well, we don't have it, so you can either walk out of here, but you can't walk because your leg's broken.
All right, team. Jacob, you got. This one's on. This is good. And I'll give it over to our next panel here in just a moment. But it's been so reinforcing that the planning committee and the staff worked hard on this, and it's pretty clear we got the right people together to talk about this issue, because the dialogue has been pretty much nonstop since we started this morning, and that's pretty darn impressive. So I'm happy. Robot. Now we come to what I think is probably the best part of the day. I grew up in a medical education where we learned through focal problems. I didn't sit in lectures listening to the biochemist tell me about the ATPs for the 45th time in my life, et cetera. We had a small group of students, 3 faculty people, and we went through clinical cases, and we studied the anatomy, the physiology, et cetera, all associated with that. Because adults actually learn through problem solving more effectively than they do in a pedagogical environment. And Matt Winnia is going to work with a team of folks here to bring us to that kind of discussion, more of a adult learning environment that is problem-based. And they'll cover the 4 scenarios I mentioned earlier today about shortage as it plays in a disaster environment. And with Matt today are Jim Hodge, who's a professor of public health law and ethics out at Sandra Day O'Connor Law, out in Arizona. Lou Rubinson, the 3-piece guy you heard from earlier. I don't think I'd ever seen Lou in a 3-piece suit. It was either scrubs or camis when we worked together. He's at the University of Maryland Trauma Center, as he noted. Monique Mansoura, who you heard from earlier today, who is with Global Health Security and Biotechnology Group at MITRE, and a former ASPR person. And Sherry Fink, who asked a question earlier today in her journalist role. And Matt, I'm going to turn it over to you, buddy.